First of all, thank you all for participating and joining this webinar today. It's absolutely spectacular to see like 5 pages of names on my screen. So thank you all. So we're really excited to convene this group of people who really care so deeply about the mental health of children across the state of Pennsylvania. My name is Anne Marie Healy, and I'm the Executive Director of Philadelphia Health Partnership. And I'm also co-chair of the Pennsylvania Health Funders Collaborative. At PHP, we aim to improve the health and well-being of people in Philadelphia by advocating for and resourcing quality care and services. And also, just to give you a little idea of what the Pennsylvania Health Funders Collaborative is, we strive to improve the effectiveness of the health funders initiatives by collaborating, networking, sharing best practices, and also creating a unified voice working in communities across Pennsylvania and especially around policy and systems change. So I'm really honored to participate in Children's First webinar today. We're really also really privileged to have Children First as one of our grantee partners here at Philadelphia Health Partnership. So as a background and to set the stage, Children First convened a summit in the fall of 2022 that was focused on finding the next big thing, big ideas that will pave the way for opportunity for children in Pennsylvania. At this summit, we heard from students, parents, youth development professionals, and educators, as well as administrators, advocates, and policymakers who build our knowledge around the challenges that our children face today. We heard loud and clear that mental health is a priority topic for families across the Commonwealth. So some of those themes that we heard from the community included all kids need to be included in mental health supports. Kids need to be supported across settings in schools, at home, and in their communities. And we need to think more upstream to intervene earlier before kids become disrupted or in crisis. And we also need a culturally relevant workforce who has relevant shared experiences of kids we are serving. In other words, we need to have a workforce that is made up of the demographics that reflect the kids being served. It should be youth-led, youth-empowered. So after hearing the themes, Children First and their partners set to work to enact these big ideas. Children First has conducted research on models in other states. They read Medicaid policies and service regulations, which, as we all know, aren't the most exciting things to do. But they really focused on understanding what is possible in Pennsylvania. They hosted an expert on children's behavioral health reform last fall to sow the seeds that Children First is delivering today. So in this webinar today, we will learn about 5 strategies that synthesize the themes heard into actionable policy changes that are possible for Pennsylvania to enact. And now it is my privilege to introduce our moderator for this event, Mike O'Brien. Mike is the founder of Humanature, a management consulting firm that puts humans at the center of workforce and organizational development. He is also a distinguished resident fellow at Drexel University's Lindy Institute for Urban Innovation. And I've had the great pleasure of working with Mike in other areas. So Mike, the floor is now yours.
Thank you so much, Erie. Good to see you this morning or now afternoon, and such a kind introduction. So good afternoon, everyone. I'm super inspired and eager to be in this space with you all and really excited to hear from this incredible panel that is lined up for you today. I'm here to discuss a bit of the vision and the why behind the reforms that people are going to touch on today. And the vision presented today to reimagine children's mental health in Pennsylvania is one that is based in recognizing strength, preventing trauma, and frankly, common sense reforms that will improve the lives of children. I'd also like to add that this is about an investment in the future of children that we actually want to see. As much as we are thinking about the reforms as prevention and intervention, they're also investments in what we want to happen, not just what we want to prevent or intervene in terms of their lives. But in that context, why do we need to start with reform? What do we know about our system that is not working? So, according to the most recent PA Youth Survey, 41% of students report feeling sad or depressed most of the time. Almost 19% of students report intentionally harming themselves. 16% of students planned their suicide, and 12% attempted suicide. And yet, only 50% of the kids who die by suicide in Pennsylvania have ever received behavioral health services. I just said a lot. So I want to kind of just breathe into that moment a little and let that sit with us. When children have a sore throat, let's get even more personal. Where if you have children that you care about or love, even if they're not technically the ones you're raising, when they have a sore throat or a stomach ache, you can take them to a doctor to get an antibiotic or clear up the symptoms, or at least you know where you might go if that happens. People tend to try their best to take their children to the doctor regularly for visits, for flu shots, or to prevent ailments. However, when children are not feeling well mentally, where do you go? Where's the first space you can get to help you make sense of addressing the mental challenges that are in your child's face? Maybe you call a therapist's office and you end up on a waiting list. Maybe you try to figure out what services that you can get through health insurance or what it will cover if you're, able to do that. If you have health insurance, right, provided through a job or whatever other means can get you health coverage, right? We unfortunately do not have a mental health system that is fully supportive of youth mental health and well-being, particularly in the context of their development. And the system responds and reacts to kids and young people once they are acutely impacted or sick or unwell. The way the system is structured now, families with means are able to pay out of pocket to meet the mental health needs and developmental needs of their children. But where does this leave the varying families across the state that are economically disadvantaged? Where does this leave their children? So we are proposing a set of reforms to the Medicaid mental health system because Medicaid is the largest insurer of kids in the Commonwealth. These reforms have the potential to impact the most kids across the state. And the reforms are based in the reality that the Pennsylvania Department of Human Services is not utilizing its full authority to maximize funding and drive innovation and reform in the way mental health services are delivered in Pennsylvania. What's interesting is that the conversation around mental health usually stops right here. There is a lot of doom and gloom in our field, but we are here today to talk about solutions. So, what do we envision? We envision a comprehensive set of mental health reforms that utilize all available funding resources to reinvent an effective mental health system for children, a system that relies on prevention, relies on health promotion, and a robust continuum of therapeutic options. Services will be delivered in schools and other accessible settings utilizing a culturally competent system of diverse paraprofessionals and professional providers. When we looked at what other states have been doing to innovate their children's mental health systems, a few lessons became clear. The first was the work must be youth led. We cannot make reforms to youth mental health systems without co designing with those who are most impacted and without them leading the efforts alongside other voices. Other states have been leveraging federal Medicaid guidance to innovate within allowable parameters. So this has looked like providing services in accessible settings like schools, homes, a variety of community settings, allowing life experiences as a criteria to receive mental health services, maximizing Medicaid dollars by identifying a diverse array of state funding streams that are eligible for a federal match. This has also included utilizing a public health approach to mental health through health promotion, prevention, and early steps in identification. With this research in hand, Children First has proposed 5 reforms that are possible for Pennsylvania to make, and we believe these reforms will greatly improve the mental health system for our children. So these 5 reforms are: 1, increase resources for prevention, early intervention, and less intensive services known as Tier 1 and Tier 2 supports. Two, broaden the types of providers certified and eligible to deliver services at each tier of intervention to increase access to diverse and culturally competent professionals. The third is to ensure that the definition of medical necessity is fully applied to authorize mental health services and payments for all eligible children. Four, that we would integrate mental health services for parents and young children in pediatric primary care settings. And five, we will center schools as critical partners in mental health care systems and payer networks. Listen, we have a great panel set up today. You're going to hit on these points. And this panel is set up to provide several different perspectives across the child and youth mental health system. We will hear from a youth advocate, a payer, a child psychiatrist, and a trauma-informed researcher. Each perspective is representative of the diversity we need at the table to build out these reforms and champion them. And I want to thank each of our panelists for being here today. So let's begin with Dr. Megan Corrado, professor at Westchester University and founder and executive director of Storiez, Inc., a trauma-informed organization that uses the principles of creativity, voice, and honor to support a diverse setting of youth navigating life challenges. Take it away, Dr. Corrado.
Thanks, Mike. Hi, everyone. It's great to be here with you all today. There's so much that can be said about this particular topic, and all of us are going to come at this from our different vantage point. I come to this conversation from the perspective of a clinician who's been working with kids who've experienced trauma for a decade and a half, and also as somebody who's experienced trauma as well. Where do I start? So I think one of the big challenges that we're facing is that we are waiting too long to introduce strategies and to provide tools to kids. We are in a space where we are very reactive. And we look at different situations, like these big situations that happen in the news, which are, no doubt jarring, traumatizing. We hear about shootings, we hear about mass killings, we hear about kids harming themselves, and that's when we react. When in reality, we're a very reactionary system as opposed to being a proactive system that says, not just what do we do now that we're here, but what can we do prior to getting to this moment so that less kids, less teenagers, less adults get to this moment in the first place. I think a question that we have to ask ourselves as well as is whose responsibility is it societally for us to introduce coping strategies and emotional regulation skills? And I think that many of our systems are pointing the finger at the other systems saying, no, it's your responsibility. No, actually, it's your responsibility. And we're waiting for someone else to do it. If we actually look at many of the behavioral challenges that we see in childhood and adolescence, also into adulthood, they oftentimes go back to difficulty managing emotions, difficulty identifying and implementing coping strategies. And when we ask the question, well, who taught them that, or who's supposed to teach kids, ways to navigate their emotions, we're at a loss. We can't necessarily identify and pinpoint who exactly it is that we think it's their responsibility. And because we're pointing the finger at all these different systems, we are missing out on really significant, tremendous opportunities to be able to educate people at a very early age. And we know that if we are educating kids at a very early age, when they go into adulthood, they have those skills, they have those strategies, not only for themselves, but also to support the next generation. And we also know if they do not have those strategies, if they do not have those skills, they do not have those things to carry with them to the next generation as well. I think a lot about the role that schools play. So oftentimes people are like, kids are supposed to learn how to express their emotions in schools. Well, yeah, but teachers also have a really heavy burden, a lot of curricular demands, a lot of benchmarks that they're trying to achieve, many things that are coming into the classroom that they are not necessarily trained or equipped to be able to navigate and handle. Or then we say, it's the parent's responsibility. Well, what if you were you had experienced trauma or mental health challenges as a child and your caregiver didn't teach you? Or what if you live in a community where it's easier to be able to find, somebody who is selling drugs or who has a gun. It's easier to find that than it is to find a really supportive resource. Then, whose responsibility is it? So I like to think about, there's a theory, and it's proposed by someone named Fredrickson, and it's called the broaden and build theory. And Fredrickson says that we really need to support people, not only kids, but, people across the lifespan, and being able to broaden and build their repertoire of coping strategies so that when they are upset, they can actually choose those strategies. But the thing is that what we do societally is somebody engages in like one of these big behaviors, something that's very alarming, something that's very jarring. And we say, well, why didn't you just use deep breathing? Why didn't you use progressive muscle relaxation? Why didn't you like phone a friend to talk to them about what happened and to express your feelings? When in reality, nobody introduced many of us to those strategies in the first place. So how are we supposed to be able to use them when we're in a stressful situation? And I think another thing that we have to bring to this conversation is uh, another finger that we point is it's supposed to be the therapists, the clinicians that are broadening and building coping strategies. Well, what if you never make it to the therapy office? What if you are working with a therapist who may not be a match for you culturally? Maybe you are working with someone who, let's just say, isn't a good fit. Then what? So this broadening and building of our repertoire of coping strategies, I really believe has to be this collective effort across all of our different systems. There's a lot of opportunities, whether you are a mentor, whether you are a coach, whether you are a peer leader, whether you are a youth yourself. And it's really important for us to identify ways that all of us can play a role in helping to broaden and build those coping strategies. Unfortunately, unfortunately or fortunately, this is also going to require many professionals to share some power, which we are not always overly eager to do. So many of us are excited about our degrees. I mean, I'm excited about my degrees, to be able to say I have my doctorate in X, Y, and Z. But that also means that many of us in these professional contexts are hoarding power and knowledge. We're using these big fancy words. We're hiding strategies in these big thick books. That are using a fancy language, are not necessarily accessible, are not necessarily user friendly, and it also makes it so that other people who want to help kids broaden and build their repertoire of coping strategies are not necessarily able to access those resources. So I think that in order for us to really come together and make this happen, we have to say, how do I translate this into like normal people language, everyday language? How do I simplify this? How do I make this relatable? How do I make sure that the language is connected and that I'm presenting this in a way that everybody can access it? There's always going to be a place for professionals in providing mental health supports to communities, all different communities, but there's not enough mental health supports to go around. We all have to be a part in kind of in building the skill set. Another thing I would like to just bring to the conversation is that it's really important for us to take a long, hard look at our current kind of focus on evidence-based practice. We're talking about evidence-based practice left and right. All day, every day, it's like creeping into our bathroom conversations, lunchtime conversations. It's like EBP everywhere. And we're actually forgetting what the real meaning of evidence-based practice is, which is it includes three things. Not just one. We're always focusing just on the research. Let me see the study. What's the data from the randomized controlled trial? But that's only 1/3 of evidence-based practice. Evidence-based practice is about the evidence. It is about the research and the literature. It's also about the clinician or the helper's expertise. And it's also about the client's preference. And all three of those things are supposed to work together for evidence-based practice to occur. And oftentimes we are only doing 1/3 of that. And we're saying, this is what you need to do. And it's going to be effective for you. And I know it's going to be effective because I saw the numbers or I looked at the coded interviews instead of actually asking people, did this work for you? How did you feel about this? Is this the direction that we want to go? Like sometimes we forget that we can just ask people, do we feel that this program is effective? Do we feel that this approach is working? And if it's not, we can also ask people, um, do you have any ideas for how we can make things better? Or if we were to do a big overhaul, what would that look like?
Just checking in that that concludes. Yeah, great work. That was so well said. That was a great mic drop on evidence-based practices. That has me thinking about a lot of things. And in the context of sharing power, I think you just actually demonstrated a major way that people can actively start sharing power tomorrow, today, literally, right? That you can actually engage in listening and in dialoguing with people about the reality of their experiences without circumventing your version or narrative, because it makes it more comfortable for you to sit in the context of whatever is happening with good intentions, or the best of what you hope to accomplish, still being able to sit and listen to the experience of others, particularly young people, about whether or not your intentions actually landed in activities and operations that move the needle. So that was really powerful stuff. Particularly also, Megan, you highlighted a number of ways in which your framing and work is tied to tier one and tier two services. So thank you so much for everything you just laid out for us. Next, we're going to hear from Anaya East. Anaya is a youth advocate who works as a mentor at the Violence Intervention Program at CHOP. Anaya, thank you for being here, and the floor is yours.
Hi, good afternoon, everyone. I come here today to speak behalf on me, myself, because I am a youth, and also the rest of the youth. Um, I want to first start off by starting with the simple fact of I noticed that a lot of youth or a lot of people will go into saying that they need help with mental health and they have to have diagnosis for like certain medical treatments or just any type of medical help when it comes to mental health, period. And I feel as though that's not something that is mandatory for you to get mental health treatment, because mental health treatment can come from any type of source, just like asking questions and just listening to one another. And I say that because I'm someone who actually doesn't have any type of diagnosis when it comes to mental illness. And I struggle and deal with mental illness on a daily sometimes. But I don't have anything written out in black and white saying that I have a mental illness and I have to have treatment for this or I have to have treatment for that. And the group that I work with I work with different type of personalities and a lot of different children, and most of them doesn't even suffer from mental illness. They literally just have like little things that's wrong with them. Like some of them fidget a lot, some of them don't know how to communicate things that they're feeling. And that's what my group is based off. We actually help the youth understand and learn their feelings and their emotions and different ways that they can cope with them. I really want to focus on the school thing as well. When I was in school, I was neglected a lot by the adults. I was neglected a lot by the adults, and I feel like um, it's important for you to have people in your corner or just a good support system that understands. You have to have someone to understand you, or just the love and attention. Like some kids just really look for love and attention from other people. So they just do things and you would consider them as mentally ill and things like that. And that's not the case with them. Um, my neglection in school actually got me to where I am now, with working with the youth. And I actually enjoy working with the youth. And helping them understand the things that they're feeling in their body, and just to be able to say, this is what's wrong with me. A lot of youth isn't able to speak up and say, I'm feeling this, or this is what's wrong with me, or can I get help with this, or can I get help with that? And that's why I took it upon myself to actually engage in youth work and just let the youth see that there is someone out there that can relate to everything that you're feeling and everything that you feel like you can't talk about. Everything that you feel like you can't talk about, you have someone here that you can actually reach out and talk to. And that's just what a lot of the youth really looks for. Like, some of them don't get the love from their parents. They go out in school, they try and get it at school, they don't get it at school. They go out with their friends, they try to get the love and attention from their friends. Some of their friends doesn't actually give them the love and affection that they need. That's when they go out here and they just do things, or they have these intrusive thoughts that they don't know how to deal with. Um, Also, I also want to point the effect on that with the big words and things that is used, because there's a lot of big words that I still don't even understand with being in this type of field, that sometimes I'm really hesitant to ask questions on, because I want to feel like I know it. And I know that that's how some youth, they actually think they're scared to ask questions because they feel like they know that this is the good route for them, or this is something that they understand when they really don't understand it. I want to just stop right there for right now.
Anaya, excuse me, that was fantastic. I invite you to look in the chat because I know you were a little nervous, but I don't think you need to be nervous at all. Like there are a ton of people in the chat supporting you. Yes, I mean not even just supporting. I want to be clear here. They are agreeing with your points, right? Like they didn't know you were nervous. They're just straight up agreeing with your points. That was fantastically stated and um, well, it was so clear. Like I really just want to underscore that. I'm supposed to say things that connect, but I don't even want to like try to summarize your words because they were very, very clear. And I think people just need to sit with the reality of what was stated. And this goes back to the intentionality that we bring in sharing power. It can be really easy for us to rationalize the experience that Anaya described as neglect and say, well, there are things that children don't understand about systems when they're in school, or there are things that a young person doesn't understand. And so maybe it wasn't neglect, but it was fill in the blank. I want to challenge that very normative thing we do as adults in rationalizing why something might not have been as harsh as someone says it is for them. And let's actively practice sharing power and honoring exactly what Anaya said as a version of reality that exists for her and her peers. With that, I want to introduce Dr. Mary Ann Albaugh. Uh, Dr. Albaugh is a child and adolescent psychiatrist practicing in Erie County, Pennsylvania. She's very active in organized medicine and psychiatry as a member of the American Academy of Child and Adolescent Psychiatry, the American Psychiatric Association, the Pennsylvania Psychiatric Society, Pennsylvania Medical Society, Erie County Medical Society, and the Pennsylvania Psychiatric Leadership Council. Busy, busy, busy. The floor is yours.
Thank you so much, Michael. And I am privileged to be able to join in here with hearing the voices of Megan and Anaya. They've really set the stage, and I just want to thank them for their rich input. And I'm going to try to continue the story of what we need to be doing and how we might share that responsibility across many systems for children. And I really appreciated how Michael underscored the notion of valuing for our future. So I think we need to think about, how do we value? How do we put put our money where it's worth in valuing children and their development, and families that raise children, and communities that support families that raise children. It is something for all of us to be doing. I will just share a quick story where it pains me every time I hear it or I read it in the paper. We have a terrible loss in our nearby community with the murder of a young mother. And she was pregnant. And there were two little children in her home at the time, and 2 and 3. And in the newspaper accounts, they say, and the children were not injured. It's hard for me to even say that because the children have been massively injured, and we as a society seem to cut off our feelings or our emotions with the rest of our body. Like there is a complete disconnect, and we don't pay attention to that. And it interferes with how we understand prevention and early intervention with what is happening with a little one. So it is so important and so vital for children's development. And I will share that it's -9 months. So from the time of early till 6, there is so much happening in brain development. And if we want to value that, then we need to help with healthy families. And how do we support parents in that role? And how do we support parents in that role when we meet them where they're at, they also have hurts and challenges and difficulties in their environment that they are trying to navigate? And so we really do need to look at how do we take a whole picture of the environment externally and internally. What's happening with that parent's feelings, emotions, experiences, trauma. I know that Megan in her presentation talked about trauma and its impact a little bit. And certainly in her work with Storiez, that's a very important element. And we all experience this, and yet we don't have ways in which we can navigate it. So paying attention generationally is really vital. We can't look at just the child in front of us. That is one part of the large picture puzzle. And so we can't just look at one of these elements. We need to look at the whole. And how do we share that as a community? Really powerful what Megan and Anaya were both saying in different ways about each of our roles in this process. Right now, the way our system is set up is very often, I don't know if it's like this in every county, and it's not like this in every center, but it's significant enough that we are missing that component around family, so, and around parent. How do we support that piece? And so, as Megan says, we are often waiting and being reactive in our system, waiting way too long. So the notion of prevention and early intervention is so important. I don't know how to get ahead of that, but that would really be my goal in life, is to expand and strengthen prevention and early intervention. And if we are doing that, then we are looking at how do we support families and parents. So it is about our current system is weighted in this medical model, and I'm a physician, so it's part of my life's journey in this medical model. However, if we look at pediatrics and we look at immunizations, we do a good job in some of our components of health and whole health around being able to prevent illness, prevent measles, prevent the flu, look at how do we pay attention to that early development about language and about walking and motor skills. What we don't do as well, although early intervention does try to help with this, is around that social and emotional component. And again, it requires at times this heavy laden of must have a diagnosis. And for me, our diagnostic formulation and coding is imperfect. And so we can't wait until somebody demonstrates all the bells and whistles of an anxiety disorder, or all the bells and whistles of PTSD or depression, or at the very minimum, an adjustment disorder, which, you know, these are things to help code and to help get things paid for, but it doesn't reflect how do we get things earlier. And so if we have this opportunity then to think about and reimagine what we are doing for children, we need to look at that whole picture that includes parent and where they're at. So when I am working with families, I do see the importance of helping them understand that what one experiences and their perceptions of that. And Anaya spoke very eloquently about one's perceptions of the experience around them. So again, I'll share a quick vignette. I have parents coming in to share their worries about their child and perhaps their challenges with throwing things, having tantrums, being aggressive or not listening. And I start to gather a history of those adverse childhood events and trying to understand the timeline of the life and their environment. And the parents' understanding of that is that the child was not aware of the fighting or the domestic violence, that it was downstairs or in another room or away from, and minimizing what the child does know and how they're growing and developing and experiencing that, and not listening to that, or having the parent really not understand that that is what the child understands and experiences from their 2-year-old or 3-year-old or infant, that infants do experience this. And we can see that in the interactions, as an example, when a mother has postpartum depression and is sad, isolated, withdrawn, not able to respond. If you look at that still face design experiment, it's painful to watch, where they ask a mother who has a lovely engagement with their child, their toddler, and the mother starts to restrict her responsiveness to the child and continues to restrict that. And the child tries to outreach, and they're not able to. And they become very distressed. And so it is important to help parents understand this. And in addition to parents, we have to have a shared responsibility for our therapy workforce, and those that the parents might outreach to. What is their level of knowledge? So we've got therapists, yes, but we also have childcare and daycare. How do we support them? How do we raise them? How do we value them? They are amongst the poorest of those that are paid in our workforce, and we don't value them. So how do we have this sense that our children are our most prized resource for the future of our community, when we don't address that in early childhood development? How do we support who is watching children? How do we support that caretakers can be at a minimum? Children thrive when there's a few caretakers, not too many caretakers. How do we reduce that shift in the system where you have too much turnover? And turnover because you can't pay a living wage, and so people continue to seek and grow and develop their expertise by moving on. And so that little toddler may have 5 teachers in a year, plus the parent that's working 2 jobs. And we are not looking at that environment and how do we manage that to support them. So I think thinking about the importance of how do we communicate this information and knowledge that we have across the system. I 100% share the notion that this is all of our job, not just some of us for a job, that we look at the accessibility and resources that come much earlier. We want coordination, collaboration, and community. So the last piece I just want to think about is sharing some ideas around how do we change our thinking around workforce? And is there a role for, I think there is, integrated care where we have more experts in this whole health, thinking about mental health and physical health together, and early in pediatric universes. So I know that we have opportunities for projects right now. Again, funding is lumpy and clunky, but looking at how do we utilize collaborative care models where, as we highlighted in our opening, children do see pediatricians. And so I think I'll share some of the data. Babies are seen by a pediatrician about 7 times in that first year of life. We've got lots of opportunities there to be educating and to be monitoring that whole health and intervening and educating ahead of. So how do we get to the OB/GYN's office or the GYN's office ahead of someone looking and thinking about starting a family? How do we help support that process earlier? And if we think back to the pediatrician's office, they are seeing these children 12 more times in the first 3 years of life. So again, it's a place where we might be able to look for more ways in which we can support that. There are some other things that I wanted to highlight before I turn the efforts back over to Mike and the rest of the team, and that is thinking about some things that are don't require diagnoses. And so they do exist. They are under the radar. People don't necessarily know that they are there. One that I will highlight has been shared within the context of our extension offices, so our rural extension offices. So Penn State University, I know in Erie County, we have access, and I think it is across the state and nation, to a program called Thrive. And it is an online parenting program, but it also has an in-person and group formats that can be interactive. And it really is proactive around parenting. How do you do healthy parenting? What are the ingredients for that infant, toddler, 0 to 3, from 3 to 5, 5 to 10, and then 10 to 18? And they have 4 modules that really come from extensive work within the Clearinghouse for Military Family Readiness. And they found that that was so beneficial for those families who experienced disruptions and disconnections and losses within family structures. But when you have these kinds of resources that start ahead of some of these things, it gives people an opportunity to find a new way to manage their emotions in healthy ways rather than destructive ways when life does lead to something that might be traumatic and difficult. The others that I want to highlight are ACT, ACT, Raising Safe Kids. It's another program that, again, it doesn't require diagnoses. It is a prevention, early intervention program for parenting skills from birth to 10. There's parent-child interactional therapy. I think right now it probably does require a diagnosis, darn it. We'd figure out something for those little ones because it's something that takes us to the age of 7, from 2 to 7, to help, again, with strong, healthy relationship building and help parents understand and develop proper aligned expectations with what it means to care for children. And we have a lot of parents that are under stress with feeling overwhelmed in that regard. A shout out to doula systems and strengthening families. And I'm going to stop because it's 12:50 and I need to stop.
Thank you so much. That was excellent. You all are doing such a fantastic job this morning. I'm trying to contain my excitement so I can keep us moving. But you highlighted a number of really, really great points, Dr. Albaugh, specifically about this access to care early, excuse me, and prior to the need for diagnosis. But also, I really want to just underscore something that's really important that I hear a lot in my line of work from a workforce development, human capital systems perspective, is this support for the variety of workforce systems that have direct and often multiple touch points across the developmental lifespan of children. What is the investment there for those systems, right? There's a local researcher, I think a lot of, and practitioner clinician, I think a lot of folks know, Dr. Howard Stevenson, who says it takes a village to raise children, but what do you do when like the village also needs support and also needs help, right? And so I think that you nailed that so beautifully this morning. Thank you so much. So moving along, and last but certainly not least, is Dr. Amy Herschell. Dr. Amy Herschell is the Associate Vice President of Program Implementation and Evaluation for Community Care Behavioral Health Organization, UPMC Insurance Services Division, where she leads the development and implementation of rigorous, high-priority implementation projects and oversees outcome activities in support of program advancement. Things like behavioral health workforce development, which I'm glad to hear that and see based on our last presenter, childhood wellness, evidence-based practice implementation, school-based mental health. Dr. Herschell, thank you so much for being here.
Well, thank you so much for having me. I really appreciate being here today and hearing so much about this important work that you all are conducting and the panelists. So thank you very, very much. I went ahead and prepared a few slides. So I'm going to go ahead and share the, oh, how about that? Thank you very much. Okay, I will not share my screen because you all are on it and shared them for me. So thank you very, very much. If you could go to the next slide, please. I thought it might be helpful to give you a little bit of information about community care. And then I am going to talk a little bit about one model in particular, which is a model that we have that is a school-based model. And really to talk specifically about how it is an example of using Medicaid funding to partner with providers and with schools to offer a service within schools to meet the behavioral health needs of students within those schools pretty broadly across our Commonwealth. So I'll give you that. I'll talk a little bit about that as well. But first, let me tell you a little bit about community care. So community care is the only behavioral health managed care organization in Pennsylvania that was specifically developed as a nonprofit organization, actually, created for the sole purpose of managing and supporting the Behavioral Health Choices program across the Commonwealth. And as many of you know, the Behavioral Health Choices program is really our Medicaid funding for behavioral health. And so, as you can see, we were incorporated in 1996 and we're headquartered in Pittsburgh, which is where I am today. So just to kind of round out the rest of the state, that's where I'm coming to you from today. So if you go to the next slide, I think this just shows you, on the next slide, you can see any of the counties that's shaded in purple is one of the counties where we have the good fortune of partnering with. So you can see that community care works in 43 of the 67 of Pennsylvania's counties. And when I say partner, that really is a key word on this slide. We really view this as a partnership. So we are very, very grateful to have partnerships in these counties where we get to partner with our primary contractors, with county administrators, with providers, with youth, with family members, to really think together about what are the local needs and how can we best work together to meet those local needs, and how can we think carefully about how to use all of the funding streams to bring those funding streams together to meet that local need. And that, I think, is really one of the benefits of Pennsylvania, where we're state administered and county controlled in terms of funding. So it really, I think, helps us to be able to be creative and strategic in how we think locally about how we can make sure that resources are really at that human services kind of integrated human service, more about human services integration at that local level, which I think for states like Pennsylvania is really important because we have so much variability in our counties. We have very urban counties and we have very, very rural counties across our Commonwealth. So I think it's really important to be able to have that kind of flexibility to meet those different needs. So if you go to the next slide, one of the ways, one of the things that at Community Care, we're really committed to making sure that our members have access to high quality care in their communities. And so one of the ways in which we have tried to do that is through our community and school-based behavioral health program. And so community and school-based behavioral health, or CSBBH, is a comprehensive approach to, as you can see on the slide, to supporting youth and families with services that are accessible, integrated, comprehensive, and coordinated through a single team or service that provides full clinical intervention and responsibility without fragmentation. And so let me tell you exactly what I mean by that. So if you go to the next slide. And this was kind of highlighted as a service where it is one where we're using Medicaid funding to integrate these services. This is important. So this is a service that we'll talk a little bit about this in the next slide. We're not going to go to this yet, but in the next slide, you'll see how it really was brought together by this partnership or collaboration of multiple stakeholders. But it really is where it's a service where behavioral health providers actually provide the service in the schools and in homes. And they provide all of these different services. Now, this is actually done through, the service is CSBBH, but it's situated, for those of you who are very familiar with our behavioral health service continuum in Pennsylvania, this is situated within IBHS, or Intensive Behavioral Health Services, which used to be BHRS. So this service, CSBBH, has crisis, case management, clinical interventions, coordination of care, and consultation and training of school partners or professionals, all within this one model. So behavioral health providers actually provide all of these services. They have space within the school, but the behavioral health providers can also go into the homes to provide family therapy in the home or to do crisis intervention. Whatever is needed, essentially, this team can provide it, with a few notable exceptions like medication management. But the teams essentially are meant to be that one stop to meet all of the behavioral health needs of the child and many of the families. If you go to the next slide, this service was really developed about 12 years ago, and it was developed as a collaboration between all of the folks that you see on this slide. And what happened was that in some of our counties, there was a noted need for this kind of service because they noticed that there were a lot of kids who were in school who had services in schools, but there was a need to better coordinate those services within the schools, and a need to make sure that they were really receiving a high quality to those services and that there was efficiency delivered with the care. So all these groups came together and thought what would be the best way to deliver this care, and they came up with this model, CSBBH. It was developed and then put into place, and then over time grew and grew and grew. And I'm going to show you how many counties we're in now with this model, and then I'm going to show you a little bit about the data, because as soon as we developed the model, we then put a pretty substantial evaluation plan around the model to make sure that we really were getting the outcomes that we intended. So if you go to the next slide, right now we serve about 2,454 youth and families at any one time across the Commonwealth with this model in particular. 150 teams. That means essentially a team is comprised of a master's level person, a bachelor's level person, and they're supported by a clinical administrator, a clinical director, and an administrative director. And they are in 85 school districts and 193 school buildings in 26 counties across the Commonwealth. And served by 19 provider organizations. So when I say provider organizations, I really mean behavioral health providers. So if you go to the next slide, these are the counties in which those programs sit. So you can see a pretty large part of the Commonwealth has at least one of these programs in them. And so over the last year, we've noticed that a lot of these programs really were impacted by the pandemic, mainly because of what we've talked about already during our time together this afternoon. The workforce challenges that the behavioral health field experienced, but also the schools. The schools experienced a lot of turnover during the really any child serving system, but specifically behavioral health, but also the schools experienced a lot of turnover during the pandemic. We also know the impact of going in and out of schools that had on children. And also during the pandemic, what happened for this service in particular was that it went through a pretty significant change in I know I mentioned this detail about that it sits within a service called, or a level of care called IBHS. That level of care shifted regulations from, it used to be called BHRS to IBHS. Even though that sounds kind of simple, just the initial shifting, it actually was a pretty big change in the regulations around it. So this service was impacted by that, as well as workforce changes, the pandemic itself. So because of that, we actually have, over the last year, been taking a really careful look at CSBBH to make sure that it's still meeting the needs of children and families, and have been working very closely with providers and with many other stakeholders to make sure that it really is still meeting the needs of those children and families enrolled in it. And we've been using a learning collaborative framework to do that, which I could talk more about later if that's of any interest to folks. But if you go to the next slide, you can see that this just highlights the team composition and roles that make up CSBBH, that for each of those teams, we have a graduate level professional, essentially a master's level person, a bachelor's level person, an administrative director, and a clinical director. Now, we can have more than one MT or BHT that's assigned to any one school, but this essentially is the minimum. And if you go to the next slide, you'll see that these are some of our program outcomes. So what I just wanted to highlight here is that this represents about 2 years of outcome data from our programs. And this is looking across all of those programs. So you can see here that this represents 3,293 youth who have gone through the program. And you can see we collect these measures quarterly. We collect the child outcome survey and the strengths and difficulties questionnaire. And you can see that from the child outcome survey, and this is if you look to the left of your screen and moving towards the right. If you look at the child outcome survey, that gives us a sense of the family and child functioning. And you can see that for each of those, we see improvement in child functioning and in family functioning using this model. For therapeutic relationship, we see that the therapeutic relationship is high. And you might think, wait a minute, that line stays straight across. And we see that really as a good thing, because what to me, what that means is that the therapeutic relationship, the scale is a 10-point scale. So you can see that this is like a 9-point. Oh my gosh, my vision. This is my age speaking right here. I have to lean into the screen. But anyway, you can see it's like a 9.43. It's high, and it remains high over time, the therapeutic relationship, and it's stable. So we see that as a very good thing. And you can see, if you continue to look to the right of your screen, the second measure, the strengths and difficulties questionnaire, the total difficulties, that we want to come down over time. So the red line is parent report, the blue line is teacher report. So for both of them, both parents and teachers report decreases in total difficulties over time, and they report increases in pro-social behaviors over time. So as you can see, that we see positive outcomes associated with this model in all of these things, in child and family functioning, in therapeutic relationship, and improvements in overall difficulties, and improvements in pro-social behavior. These measures, the child outcome survey and the strengths and difficulties questionnaire, are established measures with good psychometric properties. If you go to the next slide, by the way, we also do qualitative study. We also look at qualitative studies, so also looking at what people say about the CSBBH model, and also get very good feedback from them about that, reporting things like how the model helps kids from going into higher levels of care, and overall, schools report high satisfaction with it. This is another slide just to show you a little bit more about the outcomes associated with this model. Significant improvements in child and family functioning, reductions in difficulties, and again, the high levels of satisfaction. And I also included just a screenshot of a publication. For us, we really want to make sure that as we are learning things about as we are learning, as we're doing, we also like to make sure that we are publishing our findings. We find that's a way to make sure that, as people talk about evidence-based practice, like we heard in this panel, we like to think also about practice-based evidence. And so we do follow up with our evaluation work with publishing it, because that's a way to establish practice-based evidence. And we see it as a way to helping the literature be informed about these kind of innovations in practice, and hopefully more real world kind of initiatives. So I will leave it at that and just say thank you very, very much.
Thank you. Thanks, Dr. Herschell. So you're left with me because Mike had to run at 1. I have big shoes to fill, but first of all, I just want to thank all the panelists for being here. What we just heard about from Dr. Herschell is a really great sort of innovative model that's already allowable within the parameters in Medicaid in Pennsylvania, right? They're doing community and school-based mental health. They're using care teams that include different levels of people who are trained in different interventions for mental health, and really increasing access in schools for mental health where kids are. So we wanted to highlight that model. And now we want to move to question and answer session. I know that people submitted questions before, while you registered. So we wanted to open up with a question from the submissions, but you can also take time to put questions in the chat from today. You can put it in the chat for a specific panelist, or for every panelist to answer, and we'll kind of moderate and go through the questions. But the first question that I wanted to ask, and it's for each panelist, someone submitted this and I thought it was a good one. What is the biggest barrier to all children in Pennsylvania accessing high quality, culturally relevant mental health care? So I guess we could go for who wants to take it first from the panel? Amy?
I would say that I think the biggest barrier right now is just related to workforce challenges. I don't know what others think, though. I would be very curious what others say.
I'll jump in. So I think that it's multifactored, and it's very hard to pick one, but I will add to Amy's workforce, and that is understanding what is happening for children in their development and our ability to value what is important that supports them in their family and in their community in raising them. We don't value that, I think, like we need to. And so our services are upside down.
My response would be relevance. Trying to figure out a way to say this so that it's still kind, but knowing that kind but real. Many of the services that are being provided are not perceived as being relevant to families, to kids. So why would I take time away from my basic needs, from surviving, or why would I take time away from things that I like doing to go to be a part of something that I don't feel is relevant? Not that I'm not saying that all programs are irrelevant. I'm saying that and sorry, I'm not able to turn my video on right now because I have a little baby who's a little upset right now. But like you're going to, if I don't perceive it as being applicable to me, if you're using language that doesn't make sense to me, if you're not connecting to me, if you're not helping me understand how what we're doing now is going to affect me for the future, or is even going to affect me for now in my peer relationships, in my daily life, why am I going to prioritize it? And I think that the relevance also connects back to the cultural competence. So many of our organizations are saying that we're doing diversity, equity, and inclusion work. But then when we're working with populations of color or marginalized communities, other marginalized communities, we're not even speaking the same language. So we have something to offer, but it's not being perceived as relevant.
That was great, Dr. Corrado. Thank you. And that, yeah, well, someone just said in the chat, it echoes what Anaya shared. Anaya, do you want to share anything about your experience in accessing, what's the biggest barrier to accessing mental health?
Hey, I would say the biggest barrier for it would be like basically what I was saying, like not being able to ask for help and then having the adults not noticing the challenging things that they see within their youth. Like when I was going to school and I was dealing with the things that I was dealing with and I was being neglected by like the adults and things like that, I just felt like they should have been a little bit more hands-on on me because they know how I am as a person. And knowing that I can't or I'm not able to express what I'm feeling or understand what I'm feeling just to say that I need help with these type of things, and them knowing that these are things that they see and that I'm lacking in or that I might need help with, they don't reach out or ask that. So it's like, well, why would I, me being a youth, if I see that there's nobody that wants to help me, why would I just saying how you think, why would I want to go out and look for the help myself?
Thank you. Yeah, and so I think some part of the report and the reforms that Children First is putting forward is really getting at this issue of workforce, and also what Anaya and Megan are describing around adults who care for youth. You know, they can also be, we can leverage, there's already really great youth development work happening. And how can we leverage that work happening using Medicaid as a sustainable funding source to then have those youth serving adults be able to be support people and providers in the mental health system, even though they're not traditionally trained mental health professionals. So that's one of our reforms that's in this report that we're putting forward today. Thank you, panelists. Another question. This is from Grace. How do we as a system expand integrated care into all community-based places where children learn, play, and grow that is fundable and sustainable? It's a big question. Who wants to take that from the panel?
Me. I feel like wait, let me look at the question. So I feel like the first step to doing it is finding people like me who is actually interested in expanding the different knowledges that comes with mental health. Like I was saying, I don't have no type of diagnosis, but I do experience mental illness sometimes. And just hearing it come from me, from the youth, hearing it come from me, um, it makes them more aware of the things that they're experiencing or the things that their body is going through or even their mind is going through, because everything is controlled by your brain. So it's like if you have people who are actually willing to step up to the plate and just share some type of engagement and how they can help or even be like a listening ear to what's going on within the youth community, then that'll be good for us. Because if the youth see that there's more youth that are that are engaged with what's going on, they're going to look at it like, okay, well, let me get into this, or let me see how I can get into this, or let me just see how this can help me with what I'm going through. So that's how I feel like we should like how it can be engaged, like finding people or youth that are able to provide things uh, that are able to share things that they're going through or help the other youth to understand.
Thank you, Anaya. Does anybody else want to add?
I'll jump in here just for a moment as well. So I think about it in a couple of different buckets. So thinking formally, you know, we have some projects out there that embed mental health and wellness coaches and afford warm handoffs when families come into their primary care physician's office and are struggling with a particular question or observable concern, and be able to get some kind of intervention right there in the primary care office that might be supported by a nurse, it might be supported by a social worker, it might be supported by peer support or family support, it might be supported by a psychiatrist in the background that helps the primary care physicians. That kind of gets to be a formal structure. However, there's these informal ways in which we also look at health and well-being that's integrated in our communities. And one of those that's kind of fledgling, and it's in the state of Pennsylvania right now, it is through Visible Hands. And that is ICT, Integrative Community Therapy. And so it's not a formal therapy. It's something that doesn't require insurance. It is trained folks that are able to facilitate a group dynamic. And they talk about the pebbles, the little things that in life that just tip the balance of how do I get through day to day. And it's quite a supportive environment. And it comes out of the work in Brazil, where you have community folks come together in small groups to support each other. And this was something that really got started during the pandemic. And the Visible Hands group right now is looking at how do we expand that in our community? Similar to when you think about, I might not be calling this the right thing, but the grandmother's bench or the grandmother's where you bring in and look at what Megan was talking about earlier. We all have a piece of this. And so I'm thinking integrated in a very structured performance way in which we might fund something. Plus, how do we in communities look at what works for us to support families and children in their growing up?
Thank you. And I see a lot of resources being added to the chat. Dr. Herschell, do you want to talk about peer support?
Yeah, so I added a few resources related to peer supports. This is so a couple of sites that I hope will be helpful. One is the I was just clicking to one is the PA peer support website that will give you just additional information about the where you can find resources related to peer support in Pennsylvania, and it goes over different types of peer supports. So youth peer supports, family peer supports, behavioral health, SUD peer supports, and the upcoming conference. So that there's lots of good information on that PAPSC website. And then I also just put in the chat our Community Cares site, performance standards around peer support services. So I thought that might, those two sources in particular might be helpful for folks, just to get additional information about peer support services. I think the good news in Pennsylvania is that many peer support services can be funded through Medicaid. The tough news is that not all can be, which is not necessarily our preference. It's just the rules of Medicaid right now that certain peer support services like family and youth are not yet allowable. But there has been movement and advocacy in Pennsylvania because Pennsylvania has been one of the leaders of states when it comes to peer supports. And we've had a lot of advocacy in the state around peer support services because our peer support services have done so much for behavioral health services and have done so much to expand the workforce. So I'm really glad that this topic has been brought up in the conversation today and that people are interested because I think it's such an important topic, and additional advocacy definitely needs to be done for youth and for family peer supports. And we do have a lot of really great advocacy networks. I know on our side of the state, we have the Allegheny Family Network as well, who does amazing work. It's just that right now, a lot of work for family and peer supports is grant funded. So I think we need to be able to do more to advocate so that it's more than grant funded.
Yeah.
So I put those resources in. I'll just mention with integrated care, There are there are a number of ways that we have tried to increase integrated care through behavioral health homes, which is a model that helps provide behavioral health care and physical health care together. We have done collaborative care models, and and I'll put these resources in the chat so that folks can look at them in their own time if it's of interest. And there are also I'm blanking, I'm sorry, on the name of it, but it's essentially a line where pediatricians can call a psychiatrist, a child psychiatrist. Tips line. Yes, thank you. What is it? Is it the tips line, or is there another part of that
Children's
name?
tips. Yeah, I know in our region, the state is divided up, I think, into 6 blocks or 3 blocks. Maybe it's 3 blocks. And Abigail Schlesinger out of UPMC in Pittsburgh runs that program for the western side of Pennsylvania. I'm not sure who does middle and eastern.
Mm-hmm. But to your point, it really is thinking about when you think about integrated care, it's integrated across the continuum. So different levels of integration, everywhere from just having the ability of a pediatrician to be able to essentially call a colleague and ask for some advice about a few things, to fully integrated services. So it's really thinking about every level within that continuum.
All right. Thank you. Thank you, everybody on this panel. This was really fantastic. We heard so much today, so I think we all need to, hopefully you don't need to run to your next meeting. Hopefully you could take some time to digest what we talked about today. But just to summarize, we're talking about really big ideas here. We're talking about transforming the kids' mental health system in Pennsylvania from one that's really reactive and responsive to illness, transforming that to one that is protective, supportive, based on prevention and wellness, and really supporting kids to stay healthy instead of waiting until kids get sick to be able to get care. We're envisioning a comprehensive set of mental health reforms that are outlined in the report that we've linked in the chat. I'll also send it out because with a follow-up email after this. But we want to work with you. We want all of you who are interested in this work to really be a part of this. This is big system change that can't happen with just one organization, one person. It's really going to take all of us across the state to work together. And so I want to provide another link in our chat to hear from you and collect your contact information so that we can keep in touch and really work together on these reforms together. So I'll also send this in a follow-up email too. The recording is going to be available for anybody who wasn't able to make it. You can share this work, but really, we're really hoping to work with all of you and moving forward. Really, really appreciate your time. Really appreciate the panelists today. Really great expertise was shared here, and also, of course, appreciate our partners at PHP and Independence Foundation and Van Amerangen for their support of our work. Please contact me if you want to get in touch about anything we learned today, and I hope I can talk with you soon. Thank you.
Thank you.
Thank you. That was amazing.
Thank you. I had so
Thanks,
much
everybody.
fun.